I want you to move from overwhelmed by information to confident in what really matters. I want to help you move from being unsure towards direction and purpose in your healthcare. I want to introduce you to health experts. I want to let you in on tough conversations on women's health. I want to give you a place where you can lean in and learn how to take care of yourself. Let's transform your health. Let's get clear on your goals. This is Women's Health Unplugged. I'm your host, Dr. Jordan Robertson, naturopathic doctor. Welcome to what I'm going to call a super important episode of Women's Health Unplugged. I feel like the topic we're going to cover today is one that everyone at some point in their life is going to face, or maybe it's something that you're facing right now. We're going to talk about chronic pain. And I don't mean the kind of acute pain that you have, when you cut your finger or you have a headache. We're talking about chronic long-term pain. I'm joined today by one of my friends and colleagues, Dr. Kirstie Grifiths. She's a chiropractor and a yoga instructor that's pretty local to me, actually, in Ontario. And we're going to chat all things chronic pain. Welcome to the show.
Thank you so much, Jordan, for having me. I'm really excited to be here today.
So can you walk me through, Kirstie, I often ask my guests, how did they get to this point? And I know just before we hit record, you were giving me, which I didn't know, some of your background around research with respect to chronic pain. But I would love to know how you got to this place in your career and why chronic pain is something that you are so passionate about.
Yeah, so I was studying my undergrad. I was doing biomed at the University of Guelph. And in my fourth year, one of the requirements for graduation was to do a research project. And I won't lie to you, I was not amped about this because I wasn't really excited about the idea of research. But I discovered that one of the profs in our human kinetics department was also a chiropractor and was doing some research on chronic pain. And that sounded like something that might be of interest. So I started working with him, and the research that we were doing was super interesting. We were trying to find a way to objectify people's pain experience, because currently the landscape of pain, we don't have a lot of tools to be able to measure what people's pain actually is in a quantifiable way. And so that's what our research was doing. And so it was going through that project for me. At that time, I was considering going into medical school. It was actually in the process of going through the applications, and then realized there's this entire demographic of people that we are maybe failing to treat and to assess appropriately. And I felt that there was a window of opportunity there, specifically with chiropractic care. And that's what set me on my path to becoming a chiropractor.
And we've actually never had a chiropractor on the podcast before. And for me, I think that there's so much diversity in that profession. It's similar to the naturopathic profession. There's all people from all walks of life and all interest in evidence-based approaches and therapies. And so I've never actually had a conversation with a chiropractor on the show before, but for you, you approach this from such an interesting, evidence first sort of perspective, which is truly what this area of medicine actually deeply needs. So for our listeners who are tuning in and they're thinking about their own pain experience, why is chronic pain different? I think we should start there, because I think that's going to help us sort of break down where the gaps in healthcare are and how people can help themselves essentially. But why is chronic pain different? What is going on there?
Well, this is a loaded topic, but just to start with the basics of this, the difference between acute pain versus chronic pain comes down to the length of time that people have been experiencing pain. So I think a lot of the time there's this stigma with hearing the word chronic pain. People will hear that, even my patients, and they'll be like, oh, no, that's not what I have. The reality is, if you have been dealing with a pain problem that has lasted for longer than 3 to 6 months, it is a chronic issue. And so this kind of pain is very different from if you slept funny the night before and your neck was hurting, or you sprained your ankle and you're 2 days into that process and we're healing inflammation. It's very different, and there's a strong emphasis on how the nervous system becomes involved in creating that pain experience for us. One of the main things that distinguishes chronic pain from a more recent onset pain experience is the fact that there doesn't have to be tissue damage for there to be pain. And I'll say that again because it's confusing. There doesn't have to be tissue damage for there to be pain. And the reason for that is because it's our brain and our nervous system that is responsible for creating that conscious pain experience for us. And so if we're always looking for the source of some sort of injured tissue or a problem with the muscles or the joints, sometimes we're missing what is actually creating that pain response in people.
And I'm glad that you said it a second time, and I feel like we're going to say it a third time, is that, I think when we think about pain, we always imagine that something super sinister is happening in the area that we have pain. And we've talked about this on the podcast before with things like IBS and things like, endometriosis, and why do these patients not get better when we do surgery, right? Like we literally cut out the issue and 3 months later, they still have pain. It's hard for patients to imagine that their brain is what's creating that experience for them and not like a physical thing.
Yeah, absolutely. And I think sometimes that concept also gets confused with this idea that the pain is all in your head. And that might be the message that people hear, that they feel like they're making it up, that it's not real. But that is not what's happening here. It is a very real experience. It's just being mediated by a hypersensitivity of the nervous system that can't be detected with some of our traditional tests and assessments that we would do.
And how do we understand how that happens yet? Like why, maybe not why the nervous system does that. I don't know if we would ever understand that, but do we understand how that happens and what's happening on that, nervous system level?
There's a lot of different parts that come together here, but one of the things that my research had focused on when I was doing my undergrad was a process called central sensitization. And this is a process basically where your central nervous system, so usually your brain and your spinal cord make up your central nervous system, become hypersensitive to pain signals or even to other types of signals. So what can happen is a signal that used to come in that was a normal signal to either temperature or pressure or vibration, those would have gone through a different pathway before. They would not have been perceived by your brain as pain. But what can happen over time is that these signals can become mixed up and they can then be perceived as a pain response. The other thing we know that happens, and this is something that's been measured with a test called a functional MRI, is that we can see that the part of the brain, every body part has a corresponding part of the brain that it maps to. And usually, let's say we have an area that's feeling sore. Let's say you sprained your pinky finger. It would be a very small region of your brain that's lighting up when you have that pain. What we know with chronic pain is that over time, that map of pain on the brain becomes larger and larger and more diffuse. And so it's no longer that pinpoint area that's lighting up. We have other regions that are becoming involved, and it's amplifying that pain response.
I find this so fascinating. And I've spent some time looking at this with respect to chronic pelvic pain in women. And I loved when, you wanted to, you approached us to come on the show, and it was like talking about central sensitization. I'm like, yes, this is a theme. Actually, we're talking about this more than once on episodes. What sets patients up for this? Because not every pain experience that we have results in central sensitization or chronic pain. Are there things that are predetermining who is more likely to have that chronic pain experience or making you predisposed to that developing over time?
That's a great question. We know that there's certain things that can make it more likely for an acute situation to become chronic. What I find really interesting about this is that a lot of these factors are what we call psychosocial factors. So they involve our psychology and our social and lifestyle situation. So things like anxiety and depression, for example, if you have already been diagnosed with one of these two conditions, there is a higher likelihood that when you experience pain, it is something that can become a chronic issue. The third thing that I like to talk about a lot that has a very strong relationship with pain becoming chronic is sleep disturbances or not getting a good quality of sleep. So often when I have people who come into my office and they're coming in with back pain that they've had for many years, I would say at this point, it's almost rare to see people who don't have coexisting anxiety and or depression and issues with sleep. And so these are three realms that if we're not talking about or addressing those other pieces, it's going to be very hard to actually treat successfully that chronic pain.
I hadn't even thought about the sleep part. That's when I asked that question that hadn't even crossed my mind, but that's so interesting because I think sometimes we think that it goes the other way around, right? Like that people's pain is keeping them awake and not that their sleep is part of the perpetuation of their pain.
For sure. So all three of those things, the research has shown us that it's actually a bidirectional relationship. So it can start either way. You can either start with a pain issue and then it makes it hard to sleep at night. You can't find a comfortable position. And if that process goes on for a long time, the problem is that when we sleep, that is when we are going through that restorative healing process. If we are not sleeping well, the part of our brain that processes pain is being turned up to a higher level. And the same can be said with anxiety and depression. You can either start with those conditions and it can lead to chronic pain, or you can start with pain. And unfortunately, when you're experiencing pain, it often starts to really impact the other areas of your life. So a lot of people, if they feel that they can't engage in their regular daily activities, maybe they lose connection to some of their social groups, or if they were part of a hiking club before and they don't feel like they can hike anymore because they're having pain, now we're experiencing social isolation, and then that's putting you at higher risk for developing depression. So it does go both ways.
It's so fascinating. I want to talk about that you mentioned the piece about imaging, because from my understanding, one of these big challenges with central sensitization is also just like the chronicity of the pain itself when it's like not well addressed, or it's we have diagnostic delay, right? So the person is struggling and they are maybe seeing practitioners and maybe not, but that just the presence of pain over time has that potential to increase that transition into a more chronic pain experience. But you mentioned the imaging there, and I think that's really important because I think sometimes we put an X-ray or a CT scan or an MRI or an ultrasound on like a pedestal, and I feel like so many people are waiting for the results of these things to tell them what to do with the rest of their life with respect to their injury. Like, what are your thoughts on that? And where should we actually place imaging in the whole like line of workup?
I could go on and on about imaging because it
No,
is.
I feel like I have multiple questions about imaging.
Oh, so here's the thing. Diagnostic imaging, that includes everything from x-rays to ultrasounds to MRIs to CT scans. This is a tool that can be very useful. It's also a tool that can be misused or overused. And what we know specifically about x-rays is that they are wrongly prescribed in over 50% of cases. So what happens is we go and see our healthcare provider. We're telling them that we have back pain. And one of the first steps in many of these interactions is to send that person for some sort of imaging study. But what we've just talked about is how oftentimes there isn't tissue damage with chronic pain, right? So if we are sending someone who has back pain for an MRI or an X-ray of their back, there's two things that happen that can get very confusing for people. Number one, you wait months and months to have that MRI. You, in the meantime, are still experiencing pain. If not, the pain is probably being amplified because some of those other factors creating the pain have not been addressed. And then you get that report back from that test you've been waiting 9 months for, and it says, unremarkable, everything looks normal. And that's the end of the conversation. And that is so confusing for people. And again, I want to address for anyone who's listening to this, if you've had that experience, oftentimes that is happening because it's not an issue with the joints. It's not an issue with the bones. It's not an issue with the muscles. It's the nervous system. It's the brain that is creating that pain experience. Now, the other thing that can happen, and I would say this is just as common, is that you can see things on an X-ray that look really bad. You know, you can have really severe degenerative changes. That basically means arthritis. And when we've looked at studies where people have had, specifically looking at x-rays, who have had x-rays done, that doesn't have a strong correlation with people's symptoms, meaning that you can have someone who has an x-ray that looks terrible. It is riddled with degenerative changes and arthritis. And you can ask that person, how do you feel? That person has no pain at all. So the other thing that can happen is we go down this rabbit hole of blaming the symptoms on something we see on an image that actually have nothing to do with why that person is experiencing pain. And it creates this phenomenon called pain labeling, where now we are showing someone a picture of their spine and saying, these are permanent changes. This is what's causing your pain. And now that person is tied to this idea that there's nothing they can do to make it better because it's a permanent structural change. When the reality is that person's spine probably looked like that 3 years before they started experiencing the pain problem.
It's so fascinating. As you were talking there, the word that comes to mind is just like paralysis, right? Like whether you're waiting for imaging that we don't need, that's going to say nothing, there's this like paralysis period where you're just sitting there. And quite often, because we feel like we've put this imaging on a pedestal, people feel like they can't or don't need to do anything even until they get that answer, because like the truth is going to come from this image. And there's just this like general paralysis rather than us empowering people to, okay, yeah, like you've got an MRI booked in 2027. Let's like do some things before that happens so that we actually can maybe change your day-to-day experience or your strength or your pain or what have you. And then the opposite is I see it often in my practice because of the population I work with. People are like, oh, I have degenerative changes in my C-spine, so therefore I can't. Right? ... Or I have degenerative changes in my knee. I have arthritis in my knee and therefore I can't ... And like part of me wants to go, yeah, me too. Like I have those changes too. Right. And it's not, and I'm not discounting. There's lots of people who do have degenerative changes that are causing pain. So I'm not discounting that, but I'm saying similar to what you were saying is that what we see on their image is not like, it's not correlated with their pain scores. And what that means, just for the listener, is like if we scan 100 people and we survey those 100 people who has pain and who doesn't, we can't match up their image with their pain level, right? They're not related.
Yeah, exactly.
So it's paralysis, right? Like we're creating this paralysis in people that, and from a chronic pain perspective, that's just like, that's amplifying the experience.
It is, because it creates fear for people. And we know that fear and anxiety are two things that up the pain experience. So we're basically feeding into that pain response for people. And what we also know is that for most cases of what's called non-specific low back pain, so that includes things, like if in chiropractic terminology, joint restriction or muscle tightness, or this kind of chronic pain that we're talking about, they respond really well to rehab. So if we position exercise as a first line of treatment, those people usually get better. But if you now see an image of your spine that makes it look like if you bend the wrong way, something's going to break, it creates fear around movement. And then people don't want to exercise because they think that exercising is going to make things worse, when really being more sedentary and having that fear and letting that hold back your decision-making is actually the thing that is creating the pain.
Yeah, I love this conversation because, in my experience, looking at some of that research on chronic pain, that like when people exercise inconsistently, it actually can also like confound the way that they experience their pain, right? So if you have a sore knee and you exercise once, right, the next day your knee will feel worse, 100%. But patients who exercise 3 times per week who have sore knees actually report that the exercise makes their knee better, which I find so fascinating. Like I'm really curious about, and I don't know the answer to this. And some of the research on this for chronic pelvic pain is like really recent, like fall 2022 recent, is like if you're a consistent exerciser, the exercise makes your pain experience better. If you are really haphazard, it makes it worse. I wonder what that's about. Like, I'm curious what you think, and I'm kind of putting you on the spot because this is kind of a new concept, but like, is this about resiliency? Is this about changing the nervous system? Like, what are your thoughts on that?
Yeah, it is a little bit, I think both of those things. So it's an adaptation response. Oftentimes, when we do have kind of a flare up of pain, it's because we've done too much too soon. Our bodies are extremely resilient and adaptable, but we have to get them there gradually. So this is a good time of year to be talking about this. We get close to the new year, and it's a common time of year where people are like, I'm going to get back into my health habits. And I'll talk to patients and ask them about what their goals are. Let's say they're wanting to reintegrate exercise. And they say to me, yeah, I'm going to get back to the gym. My plan is to go 5 days a week, and I'm going to go back to lifting the weight that I was 2 years ago when I used to go to the gym. Not a good starting point, because where you left off 2 years ago is not currently what your body is capable of managing. And so, yes, we can absolutely see irritation of tissues, or what's more common is something called delayed onset muscle soreness, or DOMS for short. And this is also an important concept with chronic pain. I teach this one a lot with my patients, this idea of hurt versus harm. You can have pain after exercise. With this delayed onset muscle soreness, this is the kind of pain most of us have experienced. It doesn't come on right away. You feel good after your workout, and then 24 hours later, you're having a hard time going up and down the stairs because your quads are on fire. That is not dangerous. It hurts. It is not pleasant, but it's actually an adaptation response that tells you that the muscles are becoming stronger and it's raising your resilience. But if every time we experience something that's painful, we attribute it to being damage, we're going to want to shy away from doing that thing because we think it's making things worse. So teaching people what the difference is between pain that is actually okay and productive and important to move through in order to reach recovery versus pain that might be making things worse. I have a whole framework for that, but that's a really important piece to address to make sure that people are working at the level that their body is capable of.
I feel like my husband needs to hear that. He is the fitness rebirth. This is what we call it when you've taken like a little bit of time off and then you decide to go like 6 days in a row, and then he experiences fitness rebirth. And okay, so one thing I was thinking of as you were talking there, like, just how important the language actually is that we use to describe pain and to describe what's happening. I don't know if do you have phrases that you will share with your patients or people to help them sort of think about and describe their pain? And what made me think of it is that, commonly when I'm in the gym, and these are always all my examples of life are in the gym because I'm either right here in front of my computer or I'm there. But listening to listening to athletes talk about their pain is so fascinating because everybody's there training like despite it. And the way that we'll often describe it, it's like, my brain thinks I can't do this, even though everything is totally fine. Mm-hmm. Right. Or I have like a neuropathic pain in my shoulder. There's nothing wrong. It's totally fine. It's a nerve irritation, but occasionally my brain decides that I'm not capable of lifting weight over my head, even though everything is totally fine. But talking about it in that way actually helps me move through it in part, right? I'm not like afraid. I don't think that there's some like horrific damage happening in my shoulder. I'm like really aware that it's just it's a chronic pain experience that I'm having in my shoulder, not an injury. But I don't hear that same language in the common layperson who's talking about their arthritic knee. Like, how important is it that we reframe it for patients, and how can we do that?
Okay, so I use what's called the stoplight framework. And this is basically a way to determine if what you're experiencing is something that is dangerous pain, where you should stop what you're doing, or if it's okay to move through. So green light pain. Let's say we're rating our pain on a scale of 0 to 10. And you go into your activity and your pain level is at about a 4. And then during your exercise, you experience a mild increase in discomfort. So maybe it goes up by 1 point or 2 points. But as soon as you're done exercising, it comes back to your baseline. That is pain that is perfectly safe to move through. In fact, you can move through it and you can even increase your level of challenge because you are not damaging something. Yellow light pain is if you're experiencing that mild to moderate increase in your pain, but it's lasting after you exercise. So let's say you do your workout and then later that night, you're like, oh, my shoulder is still feeling a little iffy, or into the next day. That is still safe pain. So you can still continue with what you're doing, but you might want to keep it at that level and not increase the level of challenge until you experience a shorter duration of those symptoms. Red light pain is the one that we want to be mindful, where we maybe want to stop what we're doing. If you experience pain during activity, that is a significant increase in that pain score. So let's say you started your workout, it was at a 4, you lift something and suddenly you have 9 out of 10 pain. And this is accompanied by, let's say, a severe spasm, or suddenly you're not able to move, you lose most of your range of motion, and that pain lasts for days. That is the kind of pain that probably has irritated something, and that you do not want to keep pushing through that or working through it. You want to take a little bit of time to let that come down. But you'll notice that was the only situation in that framework where you have pain, where it's not safe to progress. The other types of discomfort, it is okay to continue with what you're doing and it's not going to harm you.
It's so interesting. I also, as you were talking, I'm like, okay, so every CrossFitter needs to listen to this red light situation and stop what they're doing immediately. Just teasing. But it's so interesting because there's so much fear around all pain, right? Like we don't like to be in discomfort, right? I don't think, and especially I love the way you were talking about those psychosocial aspects, that when people are struggling in those areas of life, whether it's loneliness or mental health, our tolerance for discomfort is actually quite low. And so you can see how, and now maybe the wheels are turning as a listener, you can see how this cycle of chronic pain becomes something, right? Where it takes hold. It's that you may be struggling in one of those psychosocial aspects, maybe mood, maybe sleep, maybe loneliness, isolation, maybe insecurity from a job perspective or financial insecurity. And then we have pain. We can't tolerate the discomfort of moving through pain because our life is like relatively uncomfortable all the time. And so our tendencies to do less and protect ourselves and protect our nervous system. But then we move less. And that perpetuates this idea that we can't exercise, we can't move. And then the chronic pain actually takes hold. It's so fascinating.
It is. Speaking to your point here, I was reading Jay Shetty's book, Think Like a Monk, earlier this year. And I came across this really interesting section that was looking at research that shows that our emotional pain and our physical pain experience is the same part of the brain that lights up for both. We can't distinguish between emotional pain or physical pain. And so if, let's say, we're exercising because we think that's going to be the thing that fixes the pain, but you have extreme financial stress, or there's challenges in your relationships, or there's something else in your life that's creating that more emotional pain response, you're still going to be experiencing pain. So again, that's why this holistic approach to what is actually creating that pain in the first place, it is usually multi-pronged for people who have had pain, again, for more than 3 to 6 months, and particularly people who have been experiencing pain for many years. There's a few different areas that we need to be looking at.
And so how do we approach that? It's not hard to see how that sort of conventional care model is really failing people in this regard and really perpetuating the less movement over time. And this paralysis, either paralysis waiting for imaging or paralysis now that you have your imaging and we've told you that shit looks bad in there and so you shouldn't do anything. But how do we start to make headway? What does the average person do to start to tackle their chronic pain?
I have a very specific kind of series of steps that I move through with patients. I think the main thing here is that this is an area where mind-body medicine is extremely useful. It's convenient. I'm also a yoga teacher, so I wanted to find something that I could treat that mind-body medicine would be able to play a role. And then it just worked out that the research that I had done and the demographic I wanted to work with was also the group that this is quite helpful for. So what I'm doing when I'm seeing patients is, in that initial assessment, the discovery phase of those appointments where we're having that conversation, asking lots of questions as a practitioner beyond just the low doctor for Cara, which is the questions that we ask to find out where someone's pain is, how intense is it, how frequent is it. We have to ask more questions than that. So asking about, what are your stress levels like in your life? What's your living situation like? What's your lifestyle like? Do you exercise? What's your diet like? We have to really get a good scope of what that person's day-to-day looks like. So for me, we go through that process first. And then the mind-body piece is addressing the physical. So as a chiropractor, we're probably best known for the manual therapy that we're able to do, adjustments and other hands-on care. And I want to be clear, that's still helpful. Like if you are someone who experiences chronic pain, you probably do get relief when you go see your massage therapist or your physio or your chiropractor, and you can absolutely continue doing those things. But then we need to address that nervous system piece. The way that I do that in my practice is integrating a format called heart math. So it's a way of regulating our nervous system and boosting a metric called heart rate variability, which is going to help to move the nervous system into a response where it's better able to heal. So in my practice, acupuncture is a great way to facilitate that. But when my patients are actually doing their acupuncture treatment, they're being led through guided meditations. And they're very specific. It introduces breathing techniques and visualizations that help people reframe what pain means and to help move into that healing response, moving into that parasympathetic nervous system. So in my experience, combining these two pieces, that would be the mind piece, the mental reframe, the nervous system being able to move that into that calming relaxation response, plus the hands-on care. That is really a way that we can start to tackle both sides of this problem together.
That's amazing. It's interesting. I just ordered an Aura ring. I'm excited to look at my HRV. That's what made me think of that. I love that approach. And I think, stopping that cycle of that like paralysis pain piece is so vital, and helping patients feel like they have a role to play, actually. Like, I think that's like the crux of all of this, is that you actually kind of have a choice to be an active player as part of your healing of chronic pain. And that's just not typically how we've positioned the patient in the way we talk about pain. We make people feel like there's nothing they can do. And it's just sad.
100%. It's actually extremely necessary for people to be actively involved in their recovery. So the other piece of what I do, about half of it is clinical care, and the other half is my recommendations and resources that I'm giving people for what they're doing when they're not in the clinic. Because if you're seeing your practitioner once a week, or that tapers off and it's once every couple of weeks, and that's the only touch point that you're having with addressing this pain, it's not going to be enough. So, prescribing people exercises that they can safely do every day to help to create that new neural pathway that tells your body it is safe to move that way and it's not going to make things worse is extremely important. And then using other tools that will help to facilitate that healing response, things like dietary supplements can be very useful for that. And then, just addressing some of those day-to-day things. So I'll also put a report together. If we realize that the person's sleep is highly affected, then we start to address the sleep piece. If we, realize that the workstation ergonomics are not helping the pain situation, if the person is sitting for 8 hours a day and they're not getting up and giving themselves positional breaks, that's probably not helping. So we start to figure out, where are those triggers showing up in your day-to-day life that might be causing that pain? And can we catch and correct those things so that we're not constantly putting the body back into that pain state?
You've said a lot of really helpful things here. I think, just to kind of circle back on some of them, one, that piece around how there isn't always tissue damage when there's pain. right? It's funny. I'd keep trying to tell my brain that my knee doesn't have arthritis. I'm sure it does. I'm like, you don't know what you're doing. You don't know. It's fine. I'm trying to retrain my brain that my knee does not have chronic pain. Pain actually does have some arthritis. But that idea that like there's not always tissue damage. Damage is not it doesn't correlate necessarily with that pain experience. And that actually can be kind of, it's like a bit ambiguous to talk about pain like that, but it actually can create a little bit of peace and relief, because to think that there's this like irreversible damage in your body is certainly not a very motivating bit of information, right? Whereas if we say to patients like, no, your brain has adapted to this situation and we can untrain that using certain techniques and therapies and exercise, et cetera, I think that's actually quite empowering.
I totally agree with you. And that's how I try to frame that too, is, if someone does get that report back, that X-ray report or MRI, and it says everything's normal, I'll, address that can that can be disappointing for people, because we want something that we can look at that says, here's the problem. But you're absolutely right. But if it is a structural thing, or we're tied to that idea that, oh, I have this thing and it can't be changed, then we do feel trapped. We don't feel like there's a whole lot we can do about that. But the brain and the nervous system, the terrible thing about it is that it can be adapted to a pathological state where we feel pain and that's a problem. But the beautiful thing about it is that it can also be adapted to coming out of that state. We can create new neural pathways. The nervous system is very plastic, meaning that it can change and shift. It's not like the one that we got is the one we have forever, but we have to create those practices and habits that are going to support that change. And the most important thing to know about that is it doesn't happen overnight. It takes a lot of repetition and consistency and time. And sometimes you're not going to see those changes right away. And it doesn't mean that it's not working. You just have to keep going with it, because these things, if you think about how long it took to develop that pain in the first place, it doesn't take 3 or 4 days for it to reverse.
Mm-hmm, mm-hmm. That's such an important point. I think, you write like the one gratitude journal, right? And then you're like, why don't I feel better?
Exactly.
But it's that constant like showing up for yourself and showing up with resiliency to realize that like, even if you have a hard day, because you're going to, that you still have to show up the next day too, actually, for us to like out train what your nervous system pattern has become around pain. But the other thing we mentioned there that I think is so worthwhile is just that piece around imaging, because we do like hold it in our hand as this, the end all be all of joint pain. And yet, right, it's not being used appropriately. It's so interesting that like the person that we're maybe even making that first contact point with is not the right person to even do that assessment. It's incredibly rare that if someone comes to me with pain, that the person I send them to is their primary care practitioner, right there. That's not, but yet that's like the average person. If we said, if you had back pain, what would you do? And they'd be like, well, I'd make an appointment with my doctor.
It's the second most common reason that people make an appointment with their medical doctor, with their GP. So it is, for many people, it is their first point of contact.
Mm-hmm. And even like I am not well equipped to do the level of physical exam that's necessary to understand someone's pain experience. And so that's like, and I probably have the same level of confidence on that as a primary care practitioner. And so what are they going to do? They're going to do the thing they have access to, which is send you for imaging. Right. And that doesn't make it the right choice. It's just the choice that they feel that's available to them. And then we wait, and then we've put a ton of emphasis on a thing, and it's not the right thing. And it's funny, now I'm getting worked up and my caffeine is kicked in this morning, is that if we told patients, if we give people an antidepressant, 60% of the time it doesn't work, or whatever. I think it's more than that. But if we told people that stat, they'd be like, yeah, that makes sense, right? Sometimes drugs don't work. We have a very difficult time using that same logic applied to diagnostic testing, because we've decided, or we've positioned diagnostic testing as it's always right. Mm-hmm. But what if we said 60% of the time the x-ray is wrong?
Mm-hmm.
Again, I made those numbers up, but that is true. Like there is truth to that. Like every diagnostic test we send patients for has an ability to catch people. It also has the inability to catch people, or it catches the wrong people.
Yeah.
But we never think about diagnostic testing that way. We just take it as like the final word on what our experience is. But it's just like the antidepressant. It is not effective 100% of the time. Sometimes we give it to the wrong person. Sometimes it catches a person and it shouldn't have. And so if we can think about diagnostic imaging for pain in that way, it makes it much more interesting why we would perhaps seek that different opinion or a more hands-on opinion, because the imaging is not the only thing.
Yeah. And there's a lot of criteria that's been created around this because, as we talked about as well, there are absolutely times when it's necessary. If I have someone and I think they may have fractured their spine, an X-ray is going to be the gold standard for being able to know what's going on there. And so there have been criteria created for most areas of the body that say if the person is presenting with this, or this, an X-ray is indicated. That should be the next step. But for what we're talking about, that non-specific chronic pain, it's usually not a great assessment tool. And so then that question's usually followed up by people where they ask, well, then how do I know what's going on? The physical exam that we're able to do is actually a lot more sensitive in these cases. So just, first of all, a history, asking the right questions, that's the best way to get the diagnosis. Your physical exam, where we're testing ranges of motion or doing some orthopedic testing or some tests for the nervous system, that's also extremely sensitive in these cases. And then in very specific cases, maybe we send for diagnostic imaging, and it shouldn't be used as the first point of trying to figure out a diagnosis. It should be used to confirm a suspicion. So if you already think, there's a possibility this person might have an inflammatory type of arthritis, something like rheumatoid arthritis or ankylosing spondylitis, then it's being used to confirm that diagnosis. But it shouldn't be the first line of what we're doing to try and figure out what's going on.
I love this conversation. I've wanted to talk about pain on the podcast for a long time. And I think it's something that either people can like acutely identify with chronic pain. Jordan, come on. But I think people can either like identify with it like in the here and now, or it's something that they've experienced in a loved one, and trying to understand that is very difficult. And empathize with that is very difficult. Or it's something that is going to be part of their health at some point in time, right? And so having an understanding of what we know about pain and the concept of pain right now, I think is incredibly valuable for people. And that's whether we're talking joint pain. And it's interesting, like the research on chronic pelvic pain for like gynecological conditions, the same thing applies. The imaging can't predict your pain. Your pain will be there whether the issue is there or not. And the longer we leave you in pain, the more likely you are to develop chronic pain. So whether we're talking about menstrual cramps or we're talking about arthritis in your knee, it's kind of the same conversation, which I find really fascinating. Where can our listeners find you, Kirstie? I would love for them to be able to connect with you and learn more about what you offer people.
Yeah, so you can find me on Instagram at the Chiropractic Yogi. I'm also hanging out on TikTok, Dr. Kirstie Grifiths, and I do share a lot of little videos with some exercises and a lot of educational information there. And for anyone who's listening to this, I also have a 15-minute free yoga for back pain class that you can download. So this is going to give a little bit of educational background information, some of the things we've talked about today, but it's also going to give you a 15-minute movement sequence and meditation that specifically targets back pain.
Amazing. Thank you so much for spending the morning with me talking about this. It's such an important concept. I'm excited for our listeners to have an opportunity to hear about pain from a different perspective and hopefully feel empowered to do something about it. Thanks so much for being here.
Thanks so much for having me.
I hope you enjoyed that episode of Women's Health Unplugged. My goal is to help you feel more confident about your health. Please remember that what we talked about today in the podcast does not constitute medical advice, nor was a doctor-patient relationship formed. If you have questions about your healthcare or about how today's topic pertains to you,
please take it up with your family doctor, your specialist, or someone on your health team.